So good afternoon, everyone. Thank you, organizers, for giving me this opportunity. So I have been assigned to discuss induction chemotherapy followed by CTRT in cervical cancer interlaced study to see is there the strong evidence to change the practice. So when we look back the treatment of the locally advanced cervical cancer, so in 1999, NCI released a statement to every treating physician that adding chemotherapy to radiation therapy will give survival benefit to the patient with cervical cancer. So they opted to add chemo and radiation depending on these 5 large trials conducted by GOG, RTOZ, and SWOZ. So which then showed the survival benefit of 30 to 50% in locally advanced cervical cancer with the addition of chemotherapy along with radiation. So after that, meta-analysis came which evaluated 13 trials which showed that there is improvement in outcome in 5-year overall survival by 66% with concurrent chemoradiation therapy. So this again endorses the recommendation that have been released by NCI. So the chemoradiation has become the standard of care in the management of locally advanced cervical cancer for more than 2 decades. Now it's been 25 years we are practicing that, and this also showed that the benefit is both for the platinum-based and non-platinum-based chemotherapy. So alongside, there have been many advances in the radiation therapy. The EMBRACE-1 study, EMBRACE-2 study, and RETRO-EMBRACE study, these all looked in how we can precisely deliver radiation therapy to have good pelvic control. So these are concurrent chemoradiation therapy followed by MR-guided, image-guided adapted brachytherapy for cervical cancers. So they saw a significant improvement in local control with delivery of high precision radiotherapy, and it turns out to be excellent local control rate of 91%, pelvic control of 87%, with overall survival of 74%, and cancer-specific survival of 79% with acceptable toxicity. So these all are proof to provide concurrent chemoradiation therapy for the treatment of cervical cancer. So additionally, there have been studies going on with the chemotherapy. So upfront gemcitabine and cisplatin followed by brachy, which showed there is 9% improvement, but with greater toxicity. The Outback trial then reported which did not show any improvement in overall survival or progression-free survival then. So there have been the trial and many trials which try to study the induction chemotherapy. They failed to show, meta-analysis was there and which failed to show improvement in overall survival with neoadjuvant chemotherapy. But they did something, noticed something interesting. They saw association between outcome and short course dose intense neoadjuvant chemotherapy, which have some benefit. So that was the basis. They initiated a single arm study and they see the objective response, and on the basis of that, the interlaced trial, which we will discuss now, have been initiated. This is international randomized phase 3 open label trial. So the patients were stratified according to their stage, side, nodal stages, how we deliver radiotherapy, tumor size, and squamous histology of the cell. The assigned arm were 2. The one is study arm is the induction arm, where they give 6 weeks of induction chemotherapy, every weekly 6-week induction chemotherapy comprising of 80 milligram per meter square of paclitaxel and carboplatin under 2 AUC every 6 weeks, and on 7th week they will be given the standard chemoradiation therapy, and other is the standard arm comprising of the chemotherapy and concurrent chemotherapy and radiotherapy. And the radiation therapy was provided to 40 to 50.4 gray with brachytherapy EQD2 of 78 gray to the point A. So these were the inclusion and exclusion criteria for the enrollment. And the primary objective then set was progression-free survival and the overall survival. And the secondary endpoints set were the safety, pattern of relapse, quality of life, and time to second treatment for the cancers. So seeing the demographics of the patient population that are enrolled in the interlace study, so the average age ranges from 24 to 70 in both the arm, in the CRT arm and the NACT followed by CRT arm. Most of the patients are with ECOG performance status 0 and 1. Most of the stages were stage 2B and 3B, but this study started during 2012, so they have used FIGO staging 2008 to stage the patient. Most of the histology were squamous cell carcinoma. Many of the positive node patients are there, so we can make that most of the high-risk patients are included. So when we see the Kaplan-Meier curve for the progression-free analysis, at the end of 5 years, it has been shown that there is 64% improvement with the CRT arm and 70% improvement with the induction arm followed by CRT. So similar for the Kaplan-Meier curve for the overall survival, at the end of the 5 years, it was shown that 80% for the study arm. So they have shown there is 8% difference in benefit with the induction followed by CRT. So again, analyzing the adherence to the therapy. So most of the patients who are receiving the paclitaxel arm, at least significant, around 230 patients completed at least 5 cycles of chemotherapy, and the treatment duration, they were ranges from 5 to 53 were completed from start of treatment to the end of treatment. And in the concurrent arm with cisplatin, at least 224 patients completed at least 4 cycles of cisplatin. And all the patients in both the arm completed radiation therapy. And the mode of delivery of radiation therapy were 3D conformal and IMRT. And the patient received brachytherapy. It were 2D, 3D, and 3D HRCTB with dose prescription at 90. And overall treatment time was 45 days, and which ranges from 37 to 88 days. So when evaluated the secondary endpoint, the toxicity was more on the neoadjuvant group, and that was the hematological toxicity was noted. And considering the relapse, the more distance relapse was more seen in the CRT arm as compared to NACT arm. And time to next anti-cancer treatment was delayed in NACT arm. And evaluating the quality of life, there is temporary decline in quality of life in the patient with the induction chemotherapy phase, but there was no long-term differences were reported. So while summarizing, in this study, they reported that there is improved progression-free survival of 9% and overall survival of 8% with induction chemotherapy followed by concurrent chemoradiation compared to that of the standard chemoradiation therapy. There were hematological toxicity more noticed in neoadjuvant arm, but they were manageable, and more of the toxicity were noticed during the delivery of the concurrent chemoradiation time. So they also, as mentioned, the study recruited the patient during 2012, and they were staged using 2008 FIGO. So they had 3B disease, 3B and 4A disease 14%, and another flaw or what they have in this study is that they have excluded the patient who have vaginal involvement and the nodes above the bifurcation of the aorta. So we can make out that they have excluded the high risk patient. But again, when it stays this patient with using the figure 2018, 49 would be stage 3 or 4. So this also gives us a glimpse that many of the high risk patients may have included in this study also. So when looking at the adherence to the treatment, both the neoadjuvant group and CRT group seem to be adhered to the treatment protocol well, and they all received the assigned number of chemotherapy and the radiation therapy cycles. And they have also claimed that the progression-free survival and overall survival are similar to be shown from the other studies which have been done in the past. And interval from the completion of the induction chemotherapy of 6 weeks to the initiation of definitive CRT ranges from 7 to 14 days in their study. But this 7 to 14 days range have not made any impact in recurrence or the death of the patient. So in conclusion, before saying that we can adapt the interlace study and we can use for its practice, we need more evidences, and we need more evidence before we can consider it as a standard of care for all the subset of patients, because there have been inconsistent patient response to neoadjuvant chemotherapy, as we have seen from various neoadjuvant study reports. And also, they have added the 6 weeks of weekly induction chemotherapy, which will add extra time on the regular treatment duration of the chemotherapy CRT patient, and that will be a kind of burden for the patient. And it will also reduce the compliance with concurrent cisplatin. So we are here at a fear that our patient may omit or do not receive concurrent chemotherapy during the radiation therapy delivery, because they have already received the chemotherapy and have felt the toxicity. So this may reduce compliance during the concomitant chemotherapy. And there may be also the cost issue, not only for the chemotherapy purchasing, but also for our patient have to travel a long distance, they have to accompany by someone, and their logistic, everything comes into the cost. So there may be a cost issue. And neoadjuvant chemotherapy may not be needed for the majority of the patient with cervical cancer who are treated with the definitive modern radiotherapy. So availability of high precision radiation therapy have given a significant treatment benefit, as have been shown by the retro-embrace study, that there is an overall survival benefit of 74% on adding chemoradiation therapy to adaptive brachytherapy. So we have to exploit that and use for the benefit of the patient, and need more study and trial that is matched in our setting for our population. So in conclusion, the success of neoadjuvant chemotherapy critically depends on chemotherapy compliance and uninterrupted transition from neoadjuvant chemotherapy to chemoradiation. So therefore, before adopting this as a standard for every patient, we need to have a comprehensive understanding, including cost-utility analysis, are needed to draw conclusion regarding the potential benefit of neoadjuvant chemotherapy in low and middle income countries with limited access to modern radiotherapy like ours. So it is too early to adapt this for all subset of the patient as a standard of care. Rather, we need to identify those subset of patients who would be benefited by the neoadjuvant chemotherapy. And likewise, as discussed by my two previous speakers, there may have the role of molecular markers also in the cervical cancer, and we also have to explore that. Thank you.